All right. We're going to start right on time today. We got a lot to talk about. Good afternoon. My name is Chriselle Williman. I'm a member of AOPA's Diversity, Equity, and Inclusion Committee. Founded in 2022, the DEI Committee is AOPA's newest. During its first year, the committee determined its vision as well as potential ways it could support the membership. The vision established is through its members, AOPA has a multitude of backgrounds, experiences, perspectives, cultures, and diverse thought patterns that allow for creativity, growth, and innovation in a safe and inclusive environment. Our diverse expectations will enable us to better understand concerns and create solutions. The goal of the Diversity, Equity, and Inclusion Committee is to recognize all differences brought to the organization and create a culture where all feel that they matter, are respected, and belong. We support all members, as well as share resources for professional and personal growth. In 2023, the DEI Committee issued a membership-wide survey to confirm what the membership would find valuable. The committee is now acting on the biggest request for support from the membership by providing education and resources. To this end, we have been hosting webinars or providing other education activities every quarter. We've also been working to include resources in the O&P Almanac. Today, I'm excited to welcome you to our third webinar. During the next hour, along with our panelists, you will explore the unique challenges and considerations surrounding pregnancy within the O&P profession. The webinar is designed to address both supporting providers who are expecting and supporting patients through their pregnancy journey. I would now like to introduce today's moderator, Adrienne Hill. Adrienne is transforming the minds of the next generation of O&P professionals as the MSPO Program Director and Clinical Assistant Professor at Kennesaw State University. She earned her master's degree in health administration at the George Washington University School of Public Health and her BS in physics and mathematics at Spelman College. Adrienne is a certified and licensed prosthetist orthotist after completing post-baccalaureate courses at Newington Certificate Program through the University of Connecticut. In her most recent clinical role, she served as the area clinic manager at Hanger Clinic in Atlanta, Georgia. During her 17-year career tenure, she has had the opportunity to experience different aspects of O&P through clinical care, patient advocacy, and mentorship. These experiences have reinforced Adrienne's love for the field and fueled her determination to promote the profession through community outreach. Adrienne is a true ambassador of O&P and a shining example of educational and clinical excellence. Adrienne actively serves as the AOPA Women in O&P Work Group Committee Chair and sits on the AOPA Board of Directors. Adrienne, take it away.
All righty. Thank you so much, Michelle, for the warm introduction, and good afternoon to all of our attendees and panelists. Today, I have the pleasure of introducing Krista Arola and Rebecca Sprague. Krista earned her bachelor's in science in bioengineering from the University of Pennsylvania, followed by her MS in engineering design and innovation from Northwestern University, and her master's in prosthetics and orthotics from Georgia Tech. Krista was a CPO at the University of California, San Francisco for almost 11 years, serving as the pediatric clinical manager, department research chair, and residency mentor during her tenure. Krista is now the director of prosthetics and orthotics at the Hospital for Special Surgery in New York. She is a pediatric specialist with expertise in treating patients with cerebral palsy, scoliosis, spina bifida, and pectus carinatum, and she has a wonderful 3-year-old son. Rebecca Sprague, CPO, is a ABC certified prosthetist orthotist, also specializing in pediatric care, focusing on plagiocephaly, scoliosis, and congenital limb differences. She continues to work in clinical care while she teaches at Eastern Michigan University, Master's in Orthotic and Prosthetic Program, where she serves as the program director. Becca is a member of the Academy and AOPA. She serves on the board of directors for the National Consortium of Orthotic and Prosthetic Education, NCOPE, and the Association of Children's Prosthetic and Orthotic Clinics. Becca is a mom of 4 kids ranging from 10 years old to 8 months. With this breadth of knowledge, let's get started. So first thing we'd like to do is share a little bit about clinical considerations. With this being AOPA, let's have some recommendations for clinicians, managers, and business owners.
Awesome. So I'm going to start a little bit kind of on the clinician end and how they're feeling. So we've done a little bit of research on how pregnant clinicians are feeling in their jobs and in their roles. And we regularly hear during this research and during these interviews that they feel really guilty because they're the only one going through it at the time, the only one who's asking for accommodations for their pregnancy, that they're nervous, that they just want to show that they can still do their job and they don't want to look weak. And so they spend a lot of time really internalizing a lot of that and not wanting to ask for accommodations or things that they may need. But their goal, really, even amongst that, is to stay in their job. And so we're going to talk about some of the things that companies can do to help them stay in these jobs and be really, really happy. So one of the big things is thinking about FMLA and the requirements around pregnancy leave, which just recently in 2024, there was a new Pregnancy Act that instead of the previous Americans with Disabilities Act, which is what everything kind of functioned under, and there had to be a proven secondary disability after the pregnancy, which could be gestational diabetes or something like that. Now pregnancy is just considered the reason that they need accommodations. And these accommodations can range in things from making sure that respirators are provided, or tables that go up and down, or a different kind of chair, or breaks during the day. If they can't be walking for quite as long of a time, there are a lot of things that you can do. The requirements for a company are that they have meaningful conversation with the individual about how they could accommodate them and help them continue to be able to do their job. With that being said, if it is not feasible or it is out of the ordinary expensive and would harm the company, they are not required to do accommodations that could harm the company. But within that, there are a lot of options of things that they can do. And so thinking about personal protective equipment, maybe you're providing gloves, but different kinds of masks, respirators, changing the type of gloves that you may need can be really useful.
I think I would also, just to piggyback on what Becca's been saying, it's really helpful just given this sort of internalized dialogue that a lot of these employees are having with themselves, that if you as the manager working with them prompts the start of the conversation after you find out they're pregnant and they're starting to make plans, you come out and say, like, what accommodations do we need to make? Here's some ideas. We can have, make sure that we have the proper stools that go up and down. Make sure that you have the support for when you get bigger. Is there an orthotic assistant or a prosthetic assistant who can be paired with you? Can you redistribute which cycle a resident is assisting if they don't consistently have a resident? Like, can you really just plan ahead the support staff? I think sometimes coming from the manager, the troubleshooting starting with them instead of with the employee can really create an open door policy where they feel more comfortable just sharing the things that they're concerned about. And then you can find solutions together. And then it's really not them feeling like they have to ask for it, but you offering what you already can anticipate is needed and starting the conversation there. I think that can be a really positive way of connecting with your employee and having them be open and honest, even though it can be uncomfortable.
Oh, absolutely.
Because one of the things, oh, go ahead, Adrienne.
I even think of small things of, let's say, if your clinic still has your clinicians modifying their molds, just having the vise be able to be rotated so that they can kind of modify from their side versus directly in front of it. So depending on some things, I would think about even just the change of where the vise sits on the table. Could be small changes in a clinic that really can make a difference. Becca?
Yeah, I was going to say one of the other things is when you're talking to that employee, making sure so that they're not feeling like they're a burden to the rest of their staff and their coworkers and you as a company, is figuring out a plan for when they leave and when they're going to come back. So there is a lot of anxiety. We don't always know when that baby is coming. We have this general time frame, but it can happen 4 weeks before you think it's going to, and it can happen 2 weeks after you think it's going to. And people who are having babies are really trying to make sure that they're using that FMLA time. They get a limited amount of it, and that they're using that to the best of their ability. So saying, well, I think the baby is coming March 1st. I'm going to start my FMLA then, but really the baby comes 2 weeks later, can be really hard for them to say, well, I just used 2 weeks. But from a company perspective, it's like, well, I want to know when you're going. So even if you don't know that exact date, being flexible and saying, okay, during those last 4 weeks, we're going to taper your new evals. We're going to move those onto other people. We're going to make sure you're doing deliveries, but we need a really detailed WIP list so that if you go 4 weeks early, before we're planning on it, that everybody knows what needs to be done. If you have to divide up the work among the employees who are still there, being able to do that ahead of time and knowing that having to shoulder that extra load ahead of time can be easier for the people who are still there, knowing that like, all right, here's what I have to take on during that time period, but this is the plan for it. But if you have the opportunity to bring in extra help, 1 or 2 days a week, even if it's not full time, but a little bit of help to fill in that gap for the employee who's off on leave, can be really helpful because the person who's leaving is feeling a lot of anxiety over what's going to happen to their patients and who's going to take this on, and am I being a burden to everybody around me? But the employees who have to stay are going, I'm already at a full load. How am I going to take this on? So making sure that there is a detailed plan in place and everybody knows what their role is going to be while that person is on leave.
Oh, yes, absolutely. That's excellent. It makes me think of crossover, right? So really thinking about the crossover, not just before or pre-baby, but also post-baby. Maybe if they did bring someone in that is, from outside, maybe having 2 weeks or 3 weeks that they cross over post returning back from FMLA. So absolutely, that's wonderful. So let's talk about that because those really truly are family dynamics. Can we shed a little light on things to consider family dynamics wise?
So we can sort of approach family dynamics. We can talk about family dynamics from the perspective of our family building and planning for our clinicians, and then also for our patients. So we can kind of approach it from two avenues. So I'd say understanding just for our employees when they're coming back, what's the ramp back in going to look like? What does their family look like? Is this the first child or is this the third child? That might change what their work schedule might look like coming back if they already have several other children that they need to balance the care for. And I think just really understanding the home situation and the support that they have will help you make a better plan for ramping clinicians back in. I think the expectation of, okay, maternity leave is over, full time, 100%, you're back. Well, there's pumping. There's a lot of things that you might still have to have the schedule flex for, even though somebody might come back 5 days a week right away. And so knowing that or planning that ahead and knowing that in advance, and also just finding creative ways to have alternative ways for them to work. Maybe they do more of the documentation protocol development for your department if there are kind of more administrative tasks that they could do for a period of time while they're not able to be patient facing as long. So just kind of thinking about that for your employees.
And one of the things that you want to think about before we move on to the patient side is that time everyone thinks the baby comes and we have no more doctor's appointments. And that is so backwards. There are so many appointments after that baby comes, for mom and baby. And so with a lot of company policies, you're using up your vacation time before you're getting that short-term disability and all of those benefits are kicking in. And so they're coming back from having a baby and there are still a lot of doctor's appointments and things that they may need to go to. And now they have no actual days off. So having those flexibilities that it's like, okay, well, we're open this many hours, or maybe you can work a little bit more this week and do your documentation, and seeing if there are ways that you can be flexible. And those flexibilities don't have to sit just with your pregnant employees, because that can create tension, right? Like if your other employees are going, well, I'm never going to have kids, or I'm done having kids, or, whatever that is, those flexibilities don't apply to me. But these don't have to be exclusive to patients or clinicians who are having kids. These are things that it's like, well, you have a doctor's appointment, everybody's seeing their doctor, other people have kids or they get sick. And if there are ways to create more flexibility in your weekly schedule to say, you know what, you've got a doctor's appointment, you're going to be out for 2 hours this week, maybe you can do your 2 hours next week. And thinking about more flexible options for families and clinicians.
Absolutely.
I think that's how you really retain people in the workforce. I think that's one of the big risks is think about supporting your clinicians when they're in this phase of maybe needing some temporary short-term understanding is a lot easier than replacing that person because they decide that they can't stay because of the demands being placed on them and there isn't enough flexibility for them to be in the job and continue to do the work and still be a caretaker for their children. So I think that's another way of thinking of it is like you're really investing in this person's long-term future and commitment to the company. And this might be a short-term restructuring of what their schedule looks like.
Absolutely.
So,
Do you guys think of any kind of accommodations that clinic managers or business owners could kind of have in mind on that return? If it is maybe setting aside one of the clinical rooms or a different office for pumping or just mother-baby time, I'd love to hear your thoughts.
I would say one of the biggest things I have heard from, I've interviewed about 30 people now, is with pumping. One, it's really awkward, right? Like we know it's happening, but it's super awkward. And so making sure that there's a room they can go to and that you have that ready and you're offering it to them is really great instead of them having to be like, so what do I need? And they feel like they need to pump in their car. They are not pumping in the bathroom. You guys, please don't make people pump in the bathroom. But the space they have available to them should be a locked room. It's great if you want to let them use a patient room, but that room should have a lock on the door so that is a private space that they can go into, close the door, and not be interrupted. That would be honestly probably one of the top 2 or 3 things that I hear from women is that what am I supposed to do? Or I'm trying to pump in my car before I get there because I don't know what to do. Making sure that they know there's an option for them when they get back to work.
And I would add to that also just saves time for them to do the other clinical tasks you want them to do if they don't have to do the walk to the car, to eat their lunch in the car while they're pumping because they don't have a space. The more you can accommodate spaces being in close proximity to where they're working clinically, the quicker they get that activity done so that they can return to work. So it's not just like an accommodation for them, it's also accommodation for your other clinicians as well, because you're allowing that person to return to work faster. I think too, just really being thoughtful about considering the schedule that you create for them when they come back and giving the space for somebody to ramp up instead of coming back to a full schedule and being really careful with that. Even considering if your company is able to accommodate it and the employee's interested, coming back part-time, even for a short period of time, to give them some means for acclimating the balance of home and work demands and figuring that out 3 days a week for the first month you're back versus 5 days a week for the first month you're back can be really powerful and really helpful and lead to a lot less anxiety and I think mistakes from happening because people are overwhelmed with having their attention divided between so many different things. And so if it's possible for that to happen and that's something they're interested in, I would really encourage it. I think the employee you get 1 month out will be a much stronger one than if you have them start full blast and then they feel burnt out at 1 month because they're balancing so many different things. And if you can't do it that way, do it by having, if the person used to see 10 patients a day, maybe starting with 5 patients a day when they're first coming back. It's not like coming back from vacation. It's your body is completely drained. There's sleep deprivation. There's a lot that goes into this. And I think this is something that you can consider not just for, returning mothers, but also for returning parents, right?
Absolutely.
The
Yes,
men who
dads
go
on
on paternity leave
for
and then
sure.
come back in, they're sleep deprived too, right? So just considering that for anyone coming back from this type of leave, that they're coming back and they are not operating at 100%. So don't give them 100% schedule.
Absolutely. And it's
Yeah.
so funny. I think back, and probably all of us can attest to this. Half of some of, especially our returning patients that we have seen for years and years and years, they want to hear about the baby first. They want to hear about everything first. And so what was an hour scheduled visit is now down to 45 minutes or now down to a half hour. And so, yeah, definitely changing that kind of 10 patient to 5 patient just because of the time of that our returning patients just want to know about the baby. So I definitely understand that. And then also just thinking about the time of year that the baby's coming. So is it June? Is it December? Is it January? And the patient load that comes with that at that time of year. So a January or February baby, in terms of ramping up of patient load in your office, may be a little less. But if you have a November, December baby, the amount of patient care that happens at the end of the year because deductibles are met or whatever the case may be can be significant. So definitely kind of have that in the back of your mind as clinicians, clinic managers, business owners, and really kind of plan out what's best for your, not only your employees, but as well as your business.
Yeah.
So we
And
kind of, at the end of the day, our empathy and why we got into prosthetics and orthotics really comes down to the patient. And so let's talk about just this same slide, this family dynamics when it applies to our patients and their families.
Yeah. And the way I sort of think of it is when you have a family member who's an expected parent or they're a caregiver for somebody with O&P needs, you are really like their project manager. You're coming in and they're coming to see you, and it's the parent maybe and the child is the one that you're treating, but your job is to figure out, okay, you have a new entry coming into this family. What's the timeline for that new child? And how can we make sure that the current person you're caring for, whether it's a child or an older parent, gets everything that they need and is really set up for success? So during that kind of 4th trimester, where it's going to be really challenging for you to provide the same level of caregiving and make appointments in addition to all the appointments you'll need to make for the new child, they have everything that they need. And your job is to help them plan for that because they're not going to be able to think of all those little details. So really scheduling maintenance and fit checks more frequently than you might normally, and giving yourself the time to replace things if you need to, and think of the timeline for things more like at least 4 to 5 months post the new child being born, they need to be set. So if you're seeing them 3 months before their due date and you're seeing this, 5-year-old's prosthesis and you're like, they haven't quite outgrown it yet, but they're getting close. You still have 3 months before that due date. That might be the time to pull the trigger to do that socket replacement that you might normally have delayed a few more months because you have a little growing room left. But knowing that you want it to last 6-7 months, especially on a young child who's growing quickly, do that a little bit sooner, or starting treatment sooner. So a cranial molding helmet, for example, if it's a child that you're monitoring and the mom's pregnant with the next child, and you know that it might take a couple of months in this treatment, saying we should really start now so we're done before the next child comes, because there's a lot of appointments associated with that treatment. And really just being mindful that you are asking them the questions that need to be asked to set them up for success, and planning those appointments in advance so they're on their calendar and ready to go and everything's all set. And as much as possible, creating designs, if you are redesigning or making adjustments, that allow for them to make modifications on their own, and being very open to doing virtual visits and having, if it's something where you can fabricate the new device with additional distal end pads so that if there's longitudinal growth, you have some additional space for them to take out one of those distal end pads, or building something with additional prosthetic socks, right? Just something to allow for them to make an adjustment at home without needing to come in and see you. As much as you can prepare them for that as possible, you're really providing a lot of really helpful support by doing that. And then resources, right? Support groups, shoe clothing recommendations, anything that you can give them to take home with them that they can order on Amazon and troubleshoot with you, even over the phone or virtually, I think is really powerful. So this is something I think our society has really shifted towards with COVID, is how do we provide virtual support for our patients? So I think that's one positive outcome of that pandemic, has been us really exploring that more. And that's something that you want to be even more proactive with when you have families who are having a new little one join them and need to have the space to focus on that new little one and know that the child or adults who they are supporting orthotically and prosthetically has everything they need.
One of the things I like to do with my families is make sure they don't feel rushed during their appointment. They may have a lot of questions. They may need everything written down. But I always walk out that door when I'm done and I go, there is no rush. If you need a diaper change or you need to feed or whatever you need, this room is yours as long as you need it. And while that may be feasible in my clinic, because we have 10 rooms, maybe that's not feasible in everybody's, but try to build that into your timing to give them 5 or 10 minutes after you're done with them. So they're not like, oh gosh, I got to hurry out of here. I try to give those families a little bit of grace if they're running late. I know with 4 kids, there's always poop, you guys. And I'm sorry to say that on a professional webinar.
Absolutely.
But man, it's always there, and it's there at the worst time. And so, while if it is a regular, they're coming in for helmet visits every 3 weeks and they're always 20 minutes late, maybe that's a conversation you need to have. But if they're normally always on time and they show up 20 minutes late because somebody had a meltdown or their 7-year-old wouldn't put their shoes on or whatever it is, instead of that being an automatic, sorry, you've got to reschedule, trying to offer those families some grace that you're getting things done and you got here, but knowing that they may need that some days.
And you brought up writing things down. I think that's a great, I try to like write things down for them too, just like send them an email with a summary of the things that you talked about, because pregnancy brain is a real thing. And especially if you're going through a lot of different action items of things that you want them to do or think about, if you write it down for them, you're providing that extra little assistance that they'll remember it, know what to ask next time, be prepared.
Mm-hmm. Oh, absolutely. You always remember, there is always that mother that comes in with the full list of all the questions that she possibly had, and you only get through 3 of them and just asking, hey, can you snap a picture of that and I can answer the rest of the questions for you. They always love when we can add that little bit to ease their mind. Mm-hmm. Absolutely. So on that, so Krista, you were just chatting about that, and we talked about kind of patient considerations, and you talked about, hey, building in additional extra pads and those kind of things. I definitely want to hear your take, or everyone's take on prosthetic considerations on the, patient considerations, especially on the prosthetic side. I have had the pleasure of having patients entrust me with their care during their pregnancies. And so I really want to kind of, maybe, if you don't mind, I'd like to add a few things here in this section. So several of the considerations really go back to our education in O&P and that education of the gait cycle and really optimizing performance for our patients. One thing that really pops into my mind all the time is that center of mass, and really considering where it is as the patient goes through each one of their trimesters, and really focusing on how the body changes along with what you need to change in the prosthesis. So consider several things that you can provide to the patient during that time, thinking about adjustable socket designs, maybe a liner, so that one set can be removed in the casting process. So you'll do a double liner, a liner system, and then removing that second liner as they grow so that they can get the most out of the socket that they have. We are happy to, we just learned of the BOA system having now a code that goes with it. And so just additional things that you can think of as they're having these fluctuations. I have 2 or 3 patients that actually lost weight in their thighs versus gaining weight in their thighs. And so considering TES belts or power belts for our AK patients. And then also one thing that always hops into mind is Spanx. So Spanx are also a secondary consideration. Spanx Company or those kind of elastic companies do have kind of maternity Spanx that are available. And, you know, Spanx most of the time come 3/4 length or down to the knee. And so that can be an additional kind of control over the socket to really think about as the residual limb grows and changes without kind of having that compression at the abdomen. And then actually even just moving down the socket, and you guys can probably add to this as well, is thinking about modular components that have high ratings, because not only do we have to think about the weight of the patient, we also have to consider their pregnancy and as they gain weight, the car seat they're carrying, the diaper bag, and all the other things that come with carrying postpartumly and maybe even prepartum. If this is that second, third, fourth baby, and they are carrying the new baby inside, but also the baby that you have to console. And so thinking of not only those modular components in the weight limit they have, plus the 15 pounds or 20 pounds or 40 pounds that they're carrying in addition to. And so these really go into play for both our transtibial and our transfemoral patients. So thinking about componentry, weight gain, considering alignment changes as well. During those 9 months, and knowing that we may need a flexion plate, an additional flexion plate, or an offset pyramid, and those kind of things that really think about where the base of support is. And we may have to widen the gait a little bit to make sure that we are optimizing the gait cycle as they're walking. And, you know, some physicians may say like, hey, wear your prosthesis as long as you can, but it may end up being that you're going to a chair or some type of other assistive device, and things that we can do to assist them in those areas as well. Do you guys have anything to add?
I think it was probably you who said this the last time, and I thought this is a great idea, having your patient keep their prosthetic socket from their one pregnancy so that, you know, even if they transition back into their old socket after they lose the weight postpartum, that for future pregnancies, this could be something that they have in their back pocket to be able to start to use and in another pregnancy, that they already have that socket that you can, and every pregnancy won't look the same, but they have something that they can rely on as a potential backup in those future pregnancies as well.
Oh, yes, absolutely.
Mm-hmm.
And so you're also thinking about just accommodating the time that goes with those socket changes and things about the family considerations. So absolutely. You know, I think one of the things that we also need to consider as we're looking at this is the billing side of this. It's always kind of that sore topic at this time on what do we do billing wise. And so thinking of like, hey, is there an old socket in there? And what we're looking at is changing of componentry and those kind of things. But we also need to say that these are true justifications for alignable system, ultralight billing codes. Those are things that, as long as we're documenting and showing like, hey, this patient, when they first came to us during, you know, maybe while they were not pregnant, just even in that first or second trimester, we're up 10 pounds, we're up 15 pounds, and documenting those socket changes or those changes so that we can have interchangeable or billable items at that time. So it's not something that, oh no, she's pregnant. How do we accommodate for this? That is an actual change in their oh my goodness, just lost the word.
Their medical status.
Thank you. Yes, a change in their medical status that we can go to their insurance or their private care in order to take care of that. So I think the things that I always think about key takeaways and things to always remember, think about the BOA system, thinking about a liner type fit, quick disconnects for quick interchangeable sockets from the previous socket to their current pregnancy socket. And then also always have in mind center of mass so that we think about where and how that patient's body is changing. Anything else for you guys?
No, I think you touched on all the key points.
Okay. All right. Wonderful. All righty. So you know what, Becca, would you like to share a little bit on the orthotic side? Because just because we're in this field, we have to think about our orthotic patient cares as well.
Yeah, so a lot of it is actually similar to prosthetics. We need to think about how their center of mass is changing, that there may be alignment changes in the way that they're walking. And there might be swelling, weight changes. So really thinking about that. But some of the other things that we may not think about initially are not just size changes, but as part of pregnancy, they are going to have an increase in relaxin throughout their body. And so it's not just loosening the parts of the pelvis, it is loosening everything. So all of the ligaments throughout the body are going to become more lax. So they may have injuries that are old, ACL injuries, or ankle instability that's going to become a lot more apparent during pregnancy. And so making sure that you're taking care of those things. Carpal tunnel syndrome is really common in pregnancy and gets a lot worse throughout pregnancy for those who have it. So providing wrist splints for them, thinking about kind of those other parts of the body. You may see them as a pregnant patient and you haven't seen them before. So you're not necessarily trying to adjust an orthosis that they already have, but you're helping them manage the changes in their body through SI belts or compression stockings or the carpal tunnel braces or knee braces or ankle braces. FOs are really great to think about for your pregnant patients. They are adding a lot of weight that they aren't normally carrying. So those feet are doing a lot of work to be the base of support. So kind of thinking about those things. But one of the big things I like to talk about with people is maybe you're seeing me now during pregnancy, but those changes from pregnancy may not become apparent until up to a year after they have the baby. As the relaxin starts to go away, things start to reshift, come back in line. They may come back in alignment beautifully, but they may not. And so they may start to notice those things later on after they have the baby.
I think too, there's like a little bit of, well, pregnancy, you just have aches and pains, and just really encouraging people to be aggressive early on can avoid something from becoming a really chronic issue. So I think sacroiliac joint dysfunction is a really common, challenge that women face, and having them use those SI belts and maybe modify some of their activities of exercise earlier prevents it from becoming a very consistently painful issue that they might have all throughout pregnancy and then postpartum. So the early intervention, I think, is key. I think people get a little bit hesitant. They're like, oh, it just hurts a little bit sometimes. Sometimes start doing something right at that beginning so that you can prevent it from escalating to something that's a much more challenging problem that maybe requires a much more aggressive intervention long term than if it had just been addressed when it first presents. So really, I think being extra sensitive to minor aches and pains and almost prompting your patients when they come in, oh, you're saying you have a little discomfort here. I'm going to ask you about pain in your feet, ankles, knees. I'm going to do a little like joint review assessment and kind of poke at anything where you say, oh, maybe actually, and be really sensitive to it so that we can prevent it from cascading.
Oh, absolutely. I think of that sensitivity that you just thought about, and maybe prompting or telling your patients about foot orthotics that are available, different shoe wear that they need to consider. Because, I think all of us can attest to this, or anyone saying that, hey, when I first pre-pregnancy, I was a size 10. Baby number 1, I am now an 11. Baby number 2, I am now a 12. And that is something that I just need to accept, and they need to accept, and having that kind of sensitive conversation with your patients. Or if they did have an old ankle injury or anything like that, maybe considering foot orthotics or UCBL because of the changes that are happening in the laxity of their muscles and tendons. So absolutely spot on. So, we really did chat about a lot of things. We're at 2:40 now. Guys, do you kind of have some key takeaways that you'd like to talk about and make sure that we can kind of do like a summary of what we've chatted about today?
We could do it in the order. We could start with clinicians. I think just really being proactive about figuring out things you can do to accommodate the physical space, accommodate the safety, and also accommodate the emotional experience, and creating a safe space for your clinicians to come to you and talk about what they need and figure out a way to balance it so that it benefits your clinic, your clinician, and everyone who works with them. I think that's really key. And planning that pregnancy and family leave early so that you have something in place so it isn't a juggle of who's going to handle what. You have the backup in place. You're putting the support structures in place. You're discontinuing new evaluations early enough that you don't have a bunch of deliveries waiting on the shelf at the last minute that other people have to absorb. So just really being proactive, I think, is key for the clinical side for sure.
And I would say the only other takeaway in that area, I would say, is if you are the employee, remember it is your responsibility and your right to request accommodations that you need. But for the employers out there and the managers, it's really great if you have the ability to make those accommodations or you're aware of them, to go to your employee and say, hey, would it help you if we did this? I want to make sure that I'm ordering the right size masks. Is that, if you can be proactive with them too, while legally it is their responsibility to ask you as the employer for those accommodations, if there are things that you can do, it makes them feel really great to know that their employer cares and is taking care of them.
Absolutely. I think on the prosthetic patient side, socket design is a great consideration and key takeaway. Also anticipating alignment changes, component weight limitations that may occur, and then really pre-scheduling each one of those appointments in all of these areas.
Same thing for families, pre-schedule as much as you can plan ahead and put in flexibility and provide them with the supportive resources and tools, sometimes literally tools that they might need at home to make an adjustment if they're not able to come in right after the new baby's born, but something needs to be done. Just giving them as much resources and time and space for their appointments too, to just make them feel supported, like they're not being rushed out, they're getting all their questions answered, and you're giving them information that they can reference back later and don't have to memorize.
And with orthotic patients, the same, those weight changes, ligamentous laxity changes, if they're having any swelling issues, paying attention to the reemergence of prior injuries, that those may pop up again or become problematic, and addressing any joint pain that they're having, even if they think it might not be related, but kind of teasing that out and making sure that you're taking care of those things for them.
Excellent. All righty, y'all. So at this time, we'd like to open up the questions to our attendees as well, because we have this wonderful panel. We would love to hear your questions, your suggestions, and more about things that you should consider during pregnancy for your business as well as you as an employee and your patients going forward. So we do have a couple of questions in the chat. For those that do not have access to the chat, I'd like to read out some of the questions that are there for our panel. So thank you so much. Writing things down is super helpful for those new parents, especially those who adopted older children and have custody. Recently, there is really just overwhelming to them. So even for older children, so being a new parent always does mean parenting a baby plus our elders. And so thinking about learning about the pediatric practice that happens. Then we have another one. One of the good points that came into play was the weight limits that happen, and thinking about that prosthetically as well as orthotically. One of our attendees said that if someone asked me if I lift 50 pounds, I'd laugh at them because I don't work out. But by the time you carry the car seat and the baby and the child in at 9:30 at night, it really is, you are weightlifting. For the panel, one of the questions that came in, do you recommend donning aids to help change during those kind of range of motion changes for orthotic and prosthetic patients?
Yes, that is a great option. The long shoehorns, like the really long ones that we give people who can't reach their feet, are great. Sock donners, they don't always want to use them, but I will tell you from experience, I added 15 minutes to my getting ready schedule every morning to put my compression stockings on. It's an awful experience and it takes forever, but really going through the easiest way to put them on, helping them so that they're not trying to twist and pull and move in awkward ways to get down to their feet is really helpful. And just saying, listen, this is temporary. I'm not making you use this extra long shoehorn forever. But this could potentially prevent you from having worse, back injuries or low back pain if you use these things right now. Can be really helpful. So I think that's a fantastic idea.
There's also a couple of, if it's shoes specifically, shoe companies that are the slip-on shoes where like you could just slide into them and you don't need to reach down and tie your shoelaces. I also usually, like if you start to notice somebody doing a lot of different compensations, it's worth recommending considering doing 1 to 2 sessions of physical therapy and really engaging with the physical therapist and talking about ways to try and stretch and keep the mobility in their joints if it's not just the fact that they're big that's interfering, right? If they're getting stiffness or new injuries are coming up, just encouraging people to use physical therapy early as well as orthotic and prosthetic interventions.
Absolutely. This being our allied health partners, OT as well, in addition to PT, because they have so many wonderful solutions that they've already kind of come up with in the OT world. And so occupational therapists are also wonderful kind of breadths of knowledge when it comes to pregnancy and things for our patients as well as your employees to have as well. Becca, this may be toward you, but anyone on the panel, any lab specific safety tips for pregnant lab techs?
Yes, you should be wearing gloves and specific to the chemicals that you're using. So you can actually look up your chemical and what type of glove works best, whether that's a nitrile glove or a different thickness of nitrile glove. There are different types of gloves, and making sure that you're using the one that's actually appropriate for the thinner you're using or the glue that you're using would be my first recommendation. My second one is masks. You really should be masked all of the time. Grinding byproducts are really big, and a lot of times we have a vacuum in the lab, and so we don't think about that. But you are actually inhaling some of that all the time, and that kind of overwhelm is not good for you. So masks, specific masks for any time they should be ventilation style. Anytime there are chemicals being used in the lab, even if you aren't the one using them, or laminations happening in the lab. So those, a lot of times we think, well, I'm not the one doing the lamination, they're doing it over there, and so I'm okay. But unless you have a lab that has been certified by OSHA, what they will do is they will say, here is the radius, like this is the box that within this box, you need to have this type of respirator on. And so if you're outside of that box, okay. But if your lab hasn't had that evaluation done, I would say better safe than sorry, and use your respirator. And that is beyond just an N95. There are some, like what we use here at school is an eco resin, that if you go to a lab safety or like OSHA, one of those departments, they actually work with N95 masks. So there are some laminates and resins and things like that that you don't have to have a respirator for, but you should definitely check into what's being used in your lab, and on the MSDS, what is the recommendation? And if there's not a recommendation there, looking at the chemical, like the hazardous chemicals that are in it, and what are the recommendations for those hazardous chemicals. So those are probably the two biggest things. Noise and vibration are two that are really hard to avoid in the lab, but as much as you can, I would recommend you avoid it. We can cover our ears and protect them, but infant developing ears cannot be protected, and your belly is right in front of all that really loud stuff. So as much as you can limit your time in the machine room, I recommend it. Those are things that you could talk to your managers or business owners about, is that I recognize that this is part of my job, but maybe it's possible for me to do all of the plaster work for a few months, right? Instead of the grinding work. Or maybe I'm doing plaster and pulling plastic, but I'm not doing the finishing stuff. Are there ways to shift my job duties? Because a lot of people don't think about the noise, but the decibels they're at, those go through your belly straight to the baby. And we don't always think about that. Krista,
I was going to say, I'm going to piggyback on a couple of those things. If you do have the ability, if you work with or at a university and they can do an assessment of the space. This is something I did when I was a manager for one of our pregnant employees, was had an assessment where they checked the fumes, they tagged a couple of the employees. This is good for all of your employees, honestly, not just your pregnant ones. And so they checked the like levels of ambient chemical, right? When somebody uses, and it does take some time for that chemical to kind of dissipate through the space where it's not concentrated anymore, depending on the size of your space. If you are able to, like that box of capture, we actually put tape down to outline where that box was. So if you have the ability to do an assessment where you can tell, where the capture zone is, and you just label that capture zone, we did that so people would be like, okay, I'm going to glue here in this box with it on, with the vent on, like capturing all the fumes. And as much as you could kind of try and concentrate fumes into areas which are being serviced by kind of ventilation, that's good. And being careful of the respiratory cartridges, the types you get. Different types are better for fumes versus, and different types of chemicals versus dust. Some are good for both, and just really be, making sure the cartridge is the right type for the chemicals. And exam gloves that you use in the exam rooms are almost never enough for chemicals that we work with. So if that's what's being used, if it's just the same exam room gloves, it's probably not the right type of gloves. So doing the research to really figure out what type is non-porous enough that those chemicals won't bleed through and get absorbed through the skin.
Absolutely. Wonderful. How can we help practitioners who are in states where FMLA does not have to be paid? Are there any other solutions for them?
That's a really tricky question because FMLA doesn't actually guarantee payment at all. All FMLA does federally is guarantee your job. And it is based on how many hours you have worked in the previous 12 months. So if you are a part-time employee, you get a certain amount of FMLA that's prorated based on how much you work. If you're a full-time employee, you worked for that company for a full-time 12 months before that, you're eligible for 12 weeks of FMLA if your doctor signs off on it, which pregnancy qualifies for, having a baby. But all that does is protect your job. So really, it's not even just in states. You could have a state that doesn't have any other requirements. Like I'm in Michigan, there are no other requirements. It's all based on your employer. So if your employer offers short-term disability, if your employer offers long-term disability, what those benefits are you required, I had to use all of my PTO up before I would get my short-term benefits. Short-term benefits disability may only pay 50% of your paycheck. Sometimes I worked for a company with my first baby where it was 50% of your paycheck up to $1,000 per paycheck or something, right? So that amount may not even hit 50% of your pay, and it maxed out, your benefits maxed out. So that is to say that there aren't other really great solutions, right? Because FMLA only protects your job. They can't take away your job while you're on FMLA, but they don't have to pay you. That is a US-wide issue. There are a few states, not many, but a few that do have additional laws that require paid leave. But if you are not in one of those states, you're just really at the mercy of what your company policies are.
I will say I know California is one of them because I know somebody who used it. There are some states that have government funding for small companies for people who are going on leave that the company can apply for to help compensate that person. So some states have, I would really research that specific state that you're talking about and see if they have any particular programs that the company could even apply for to get funding to help supplement when somebody's on leave. So that's, I know California had a program for like really small companies, less than 40 employees could apply for certain programs to get assistance for people to be on leave or for different reasons, not just for pregnancy leave.
There are other ones that are available are AFLAC and Fidelity. They have short-term disability pregnancy options for patients. And so it is additional pay through your like life insurance policy or short-term insurance policy through AFLAC or through Fidelity that will pay that difference. And so please look into secondary insurances that are available for you, as well as one thing that I did, as well as some of my patients, is they took their FMLA at different times. So their parental leave. And so the mom took her kind of short-term disability and parental leave in the front end. And then so that the baby didn't have to go to daycare so fast, the father took, or the secondary parent took the parental leave after the first month, like the mother baby went on to work. And so the child actually got 18 to 24 weeks home because of the shared care and how they separated their kind of parental leave. So kind of think of all the creative ways that you can separate and work through your parental care.
Also, FMLA is calendar year.
Yes.
So if
And
the
it does not
child-
have to be consecutive.
Yeah.
Right.
Yeah. So if a child, I had my son in November, so my FMLA started in 1 year and then reset to 12 weeks again in the January. And so there are some areas where so technically you could get more because it bridges 2 years.
All right. I have one next question. Do you guys have some articles that give some recommendations on techniques of sockets on pregnancy? We can share that, and maybe since you guys are registered for this webinar, you'll receive this recording as well as any additional things that have come up here in the questions we can answer and give in the body of the email. So we will look into that for you guys. Do you have any other tips while treating patients while pregnant? Currently in second trimester and quickly learning things are getting harder and harder and taking more time.
Yes. I would say think about what is hardest for you. So, when I had my first and second, getting up and down off the floor was no big deal. I had my last one at 40. And so that up and down was significantly harder. And so I liked to use the rooms that had the up-down tables. We had some exam rooms that have them and some that don't. And I very much preferred the up-down tables, so I didn't have to go down as far. I could bring my patient up. So some of those things, definitely just think about are there other options for someone to help you? Do you have an assistant that could do some of the things that are more difficult for you? Being able to lean on other coworkers is really useful as well. But I would think first about what is getting harder. Is it managing the time? Is it, are you in a hospital and you have to run up and down the floors? And you need a little bit more time. So maybe lowering the number of patients that you're seeing in a day. Or maybe instead of having, you're used to running and doing the hospital patients just in between stuff, blocking out a portion of your day that becomes set for hospital patients or for walk-ins or, whatever that is, adjusting your schedule a little bit. And I bet Krista has some recommendations.
Yeah, I started just pre-planning. Well, one, I had a resident and that was extremely helpful. So if there is flexibility, if that exists in your clinic, if it does not, I think another thing you can really do is just being very intentional of anticipating what you might need to do in an appointment and see if you can have all the things you need set up in advance. So maybe an example would be traditionally your 1 month scoliosis follow-up, you would look at their IMBRACE X-ray, and then you might make an additional thoracic pad if they needed it during the appointment. Well, maybe you just in advance have all those pads ready to go so that you don't have to make anything during the appointment. You say, this is the type of patient I'm seeing. Here's the adjustments or things I could anticipate I might need. Can I have a technician or another clinician or somebody help me prepare all those things in advance? So during the appointment, the time you actually need with the patient is really optimized for things you really needed the patient there for that you could not have anticipated. I think even if that's not how you used to work before, because you could be quick and get it done, maybe just anticipating a little bit more now if it's possible. And again, this all depends on like what is challenging. It doesn't, if walking is challenging, that's not going to be helped by preparing things. But I think just as much as you can prepare in advance, that's helpful.
Thank you all so much. Chriselle, I will give it back to you to close out our session.
All right, really great session today. Lots of good discussion. So I want to thank our panelists Becca and Krista, and of course our moderator Adrian, for taking the time today and providing your expertise. And thank you to everyone who attended the panel today as well. Stay tuned for the follow-up email. We're going to send out the recording and, like Adrian said, any additional information. But also look out for information from the committee about the next educational opportunity that we're going to be hosting. We also will try to post resources in the OMP Almanac following this panel. So thanks, everybody. We'll let you get back to your work days. Have a good afternoon.
Excellent. Thank you.